you may be. We will be starting shortly, and while we wait to start, we will share some hepatitis highlights. And I see the attendee numbers rapidly rising, and right now we are at 130 attendees. So we'll just listen to some viral hepatitis highlights. Please play the video. Thank you.
Can you just give us a second while we try to screen share it?
Okay, so thank you very, very much. Today is World Hepatitis Day, and we are really excited to be on this WHO global webinar for viral hepatitis. My name is Dr. Fumi Leshi, and I'm the lead for the WHO Global Hepatitis Program in the Department of HIV, Hepatitis, and STI, based in Geneva, Switzerland. With me is my colleague, Dr. Niklas Luhmann.
Hello, good morning, good afternoon, everyone.
Thank you very much, Niklas. So today on World Hepatitis Day, we stand in solidarity with over 350 million people living worldwide with viral hepatitis and the 1.1 million people that die every day, that die every year from liver cancer and liver cirrhosis. Today, our focus is on the 90% of the 350 million people who do not have access to prevention, testing, and treatment services. So the theme for today is bringing hepatitis care closer to you. Before we start, I would like to just highlight some housekeeping guidance. And can I have the next slide? So what this shows is interpretation is available in English, in French, and in Spanish. And this is by clicking the interpretation button at the bottom of the screen. You can click on it and choose the language which you would like to hear. And to hear the interpreted language only, click mute original audio. The second aspect is in terms of questions and chat. So use Q&A features for questions regarding the topic and presentation. And again, the Q&A button is at the bottom of the screen. For chat, you can use this feature for questions regarding IT and logistics. And right now, I note there are 26 comments in the chat, so you can put in there your comments or questions regarding IT and logistics. Next slide, please. So this session is being recorded, and your attendance is consent to be recorded. And I'm pleased to say that the recordings will be shared after the session in 3 languages, in English, in French, and in Spanish.
Español. Muchísimas gracias.
We'll begin without further ado, and we would begin by listening to the global message and the comments of the day and opening of this session from our very own WHO Director General, Dr. Tedros. So over to you, Romina. Please play that recording.
Para concederle al doctor Tedros. Más de 350 millones de personas.
Viral hepatitis, and every 30 seconds, someone dies from hepatitis-related disease, including liver failure, cirrhosis, and cancer. An estimated 80% of people living with hepatitis are unable to access or afford care. We have the tests, treatments, and prevention tools to prevent infections and save lives, but they must be more affordable and implemented at scale. And to be most effective, hepatitis care must be delivered in communities through strong primary health care and integrated with other health services that address the full range of health needs. On World Hepatitis Day, WHO is calling on all governments and partners to scale up the use of effective tools against hepatitis. There are examples of countries in all regions, at all income levels, that are doing just that. Today, WHO is publishing a new report that shows how 7 countries are applying WHO's tools and guidelines and making progress towards the elimination of hepatitis B and C: Brazil, Egypt, Georgia, Mongolia, Rwanda, Thailand, and the United Kingdom. The success of these countries shows what's possible and gives us the confidence that with political commitment and investment, the elimination of viral hepatitis is within our reach. I thank you.
So we thank very much our DG for this message, and we appreciate his participation and his commitment to the work of WHO and for disease control and elimination, including viral hepatitis. So today we're going to have an exciting event. We have an outstanding panel of participants from people with lived experience who will share their
Grandes experiencias, historias que van a...
That's why we need to place hepatitis elimination on a very high priority. And we have experts and friends from global organizations and from countries who will tell us how they have been working collaboratively to address different perspectives in viral hepatitis. So our first speaker of the day from WHO is our director, Dr. Meg Doherty, the director of the Department of HIV, Hepatitis, and STI, who will speak with us today. And I'm going to directly ask her a question. Dr. Doherty, can you share with us some of the highlights from the new global health sector strategy and how this aligns with the theme of World Hepatitis Day for this year? So thank you very much. I will hand over to Dr. Doherty. Over to you, please. Thank you.
Thank you very much. Thank you to the organizers, and it's so good to see everybody online. I just want to thank you for speaking too, and while we nice slides. Well, we know that WHO, through both the strategies as well as through the work that we're doing on norms and standards, we're working towards bringing hepatitis care closer to you, simplifying it, decentralizing it, and ensuring that everyone has access. So for example, as a scene setter, you're quite well aware, we hope by this time, that we have 296 million people living with hepatitis B, 58 million with hepatitis C, every year 3 million new infections and 1.1 million deaths. This is a high burden. And we also know that we don't have as many people aware of their disease as or in their infection as we hope for. And we only have 10% of those with hepatitis B who are aware, 21% of. And why this matters is because either testing is far from reach, awareness is far from reach, and then once testing is done, we need to get treatment closer to people as well to improve this chronic cascade of care. We know also that the burden of death is likely to go up over time. With 1.1 million deaths per year, preventable deaths, we're close to TB and higher than HIV deaths per year. And when you bring it together with the other diseases that we're working with HIV, et cetera, we can have up to 2 million deaths per year. This is unacceptably high. So what do the strategies do? We just brought these global health sector strategies on HIV, viral hepatitis, and sexually transmitted infections to the World Health Assembly. And these strategies will hold us and provide us a pathway until 2030. These strategies built upon the goals that were set out in 2016 and the SDG goals to reduce new infections by 90% and deaths due to hepatitis B and C by 65%. And it maintains those goals, but provides us with a bit of stepwise approach to how we can get there. And it accelerates that action, gives us a monitoring framework with which we will have to report back every 2 years so that we can make sure we're on track, and provides us with an approach where we can find some commonalities between other diseases. So hepatitis doesn't have to go it alone, that you're working with the structures of hepatitis, HIV, as well as STIs, but focusing on delivering high quality services, optimized systems, generating data for actions, engaging the communities and civil society, which has been so key to the success for hepatitis, and in particular, fostering innovations. We think getting to disease and ending hepatitis will require some innovations. Just to note that there is a structure to the targets. And when we look at the specific hepatitis B and C targets, the focus is on elimination, because out of all of the diseases that we're working with, we believe hepatitis is within reach for elimination. So that brings us down to less than 500,000 new cases and less than 500,000 deaths per hepatitis B and C by 2030. Do I think we can make it? Yes, if we use our coverage, our service delivery targets, and our milestones to help guide us along the way. It requires quite a bit of shifts in how we're thinking about it. We need greater public awareness. We hope increased financial resources, and we know that many smart people are working on this to bring greater finances to hepatitis. Scale up of services within universal healthcare and primary care, but that also means simplified, decentralized services as well as integrated services working with communities, and that's what we're going to hear today. We've already started on the pathway of integration of some of our documents. You'll hear about the report later today on the 7 countries that have worked forward on prioritizing elimination. Some are getting quite close. You'll hear about new guidelines that have been developed for simplifying services for hepatitis C infection. Simply put, we need to do the same for Hep B. And for example, for key populations, those most vulnerable, those who are left behind, for the very first time at the AIDS conference tomorrow, we'll be launching a consolidated guideline looking at HIV, hepatitis, and STI for key populations. And again, these innovations are also going to be key. COVID showed us we can move science when we want to. And not only are there vaccines and optimized antivirals, we need to focus on that first step, awareness and access to testing. And we're working very hard with our colleagues and the innovators to bring better testing closer to clients and to people. So what are our next steps on 2030, and can we do this? I'm really optimistic we can. We stand ready to support member states to implement the new strategies in their national strategic plans. We want to build on opportunities of COVID. We have Hep C self-testing already. We need more Hep B self-testing, self-care, differentiated models of care, and working with virtual interventions to bring services closer to people. And we want to think eventually about how we can build upon what really scaled HIV is a test and treat approach, and how we can do that for hepatitis, so we can bring hepatitis services closer to you. So with that, Fumi, I want to just welcome everybody to the webinar, ask them to visit our website, retweet our information, and we can join the communities working towards bringing hepatitis closer to you. Thank you, Fumi, and back to you.
Right. Thank you very much, Meg, for that excellent and informative presentation and setting the scene for the event and setting the bar very high. I remember two things in your presentation, that we are close to TB in terms of mortality and even higher than HIV deaths globally, and that is significant. You talked about the linked global health sector strategy, which will bridge the gap to hepatitis elimination for the year 2030 with a focus on elimination. So once again, we thank you for joining us all the way from Montreal, Canada. I'm sure it's early morning and we really appreciate your time. We'll now move on to Dr. Philippa Easterbrook of the Global Hepatitis Program. She's an expert scientist in our team, and she led the development and launching of the new hepatitis C guidelines, which recommend a radical simplification of the care pathway to overcome barriers in access to hepatitis C testing and treatment. Philippa, thank you very much. And I will set the ball rolling and ask you, what are the key highlights from these guidelines? And what are your messages for countries for implementing these guidelines towards bringing hepatitis care closer to you? Thank you, Philippa, over to you.
Great. Thank you very much, Fumi. Well, it gives me pleasure to provide a brief overview of the key messages and some of the country implementation considerations for these new recommendations. This first slide just shows the three main products that will be accessible to you, the two policy briefs, one for the treatment of adolescents and children, the second, the simplified service delivery and the overall guidance, and with the QR code that also links to the web story. Next slide. Well, the main rationale for the development of these guidelines, and I think this was highlighted in Meg's presentation, is despite the progress towards elimination and scale up of treatment, a considerable testing and treatment gap that remains. And so the imperative to move towards progressive simplification. And just as happened with HIV, with the evolution of the guidelines towards simplification, so this has happened with the Hep C guidelines, with the treat-all approach adopted in 2018, the pan-genotypic regimens, and therefore no longer the need for genotyping before treatment, and then the progressive rationalization of the regimens to now 3 recommended DAA pan-genotypic regimens. And the focus with the 2022 update has been, first of all, on the expansion of the treatment to include the younger children down to 3 years, as compared with back in 2018, down to 12 years. And now the recommended simplified service delivery. In 2018, we'd had 8 good practice principles for simplified service delivery. That's shown in the box on the right. And now with a much stronger evidence base, being able to transition to recommendations on decentralization, integration, and task shifting. Next slide. So this summarizes first and briefly the recommendations for adolescents and children. As I mentioned, we now recommend treatment for all adolescents, older children, and younger children, regardless of stage of disease, and using the same DAA regimens as are recommended in adults. And you see the table on the right, where there is now a reconciling of the same recommendations and recommended regimens for adults, adolescents, children, which will considerably simplify procurement, and also a common algorithm for diagnosis and management. Next slide. These are the recommendations on the simplified service delivery, decentralization, integration, and task shifting, with a main message about moving treatment and care out of the specialty clinics nearer to the patient. We recommend delivery of hepatitis C testing and treatment at peripheral health or community facilities, and ideally at the same site. And that is an important message in order to promote access to diagnosis and treatment. These facilities may include primary care, harm reduction sites, prison, HIV, ART clinics, as well as community-based organizations and outreach services. There is also a complementary recommendation of integration at these sites, integration of the hepatitis C testing and treatment with existing care services at these peripheral health facilities, be they primary care or harm reduction services. And finally, on task shifting, we're recommending delivery of hepatitis C testing, care and treatment by trained non-specialist doctors and nurses to expand access. And all these recommendations were strong recommendations based on moderate certainty of evidence. Next slide. And the main rationale for these key messages was based on a very comprehensive study of a systematic review of 142 studies, 14% from low and middle income countries, that compared full decentralization, that's testing and treatment at the same site, with partial testing at one site, treatment at another, and no decentralization, and task shifting to non-specialists. Overall, there was increased uptake of viral load, testing, linkage to care and treatment with full decentralization. And for task shifting, there were comparable rates of cure between care delivered by specialists and non-specialists. And very importantly, there was a high level of acceptability and support from the community surveys for this decentralization and integration, where care and treatment is being offered in the community site near to patients' homes rather than hospitals. And I think the main implementation considerations is clearly these recommendations will need adapting for different contexts, countries and specific populations, the need to plan and coordinate, particularly for delivery of integrated care through integrated data systems, efficient procurement, and cross-training of healthcare providers. Next slide. Moving to the next recommendation on the diagnostic recommendations. This table summarizes the 2017 recommendations, and highlighted in blue are where we are updating in these 2022. So in addition to the existing recommendation on lab-based nucleic acid testing, either quantitative or qualitative, or a core antigen test, we're now recommending point-of-care viral load assays as an alternative for both detection of viremia and test of cure. And we are also, based on the existing recommendation of dry blood spots, now have manufacturers' protocols, which gives further information to support implementation, and a new recommendation on reflex viral load. Next slide. So the recommendation for the point of care is that this could be used as an alternative approach to lab-based RNA assays to diagnose viremic infection or as a test of cure. And we recommend the use of reflex RNA testing. What does that mean? Well, it can be implemented either through lab-based reflex testing, which is simply when you get a positive result, HCV antibody result in the lab, the same sample or a duplicate sample can immediately be used to prompt viral load testing in that same lab. Or if the antibody test result is from a rapid diagnostic test in a clinic setting, there can be immediate specimen collection following that positive result for a viral load test, both conditional recommendations. Next slide. And the rationale is based again on a systematic review comparing point of care with lab, showing better outcomes, faster turnaround time, increased uptake of viral load, increased uptake of treatment, and clearly the benefits of point of care that can be used at lower level health facility near where the patient's receiving care. And for the reflex testing, again, based on 51 studies, showing an increased uptake of viral load testing with reflex testing and improved linkage to care. And again, this very much simplifies the care pathway, reduces the need for additional visits, avoids the need for additional blood draws, is cost saving and feasible to implement. Next slide. And again, this was strongly supported by the community survey of values and preferences, showing strong support for having viral load testing outside of the hospital setting, to be able to do the initial and confirmatory tests on the same day at the same place. Ideally, if treatment could be started on the same day if they had a positive viral load, and where 92% wanted to be tested in treatment in the same place. So very powerful message from the community and end users of services. And next slide. And finally, on the implementation, again, very much for countries to make strategic choices about the right balance of lab-based versus point-of-care platforms, depending on the testing infrastructure, with priority use of point-of-care at harm reduction sites among persons who inject drugs at higher risk of loss to follow-up, with optimal placement of the point-of-care where testing and treatment are at the same site, the one-stop shops. And then with reflex testing, lab-based reflex being best placed in settings where there's large testing volumes supported by sample transport networks, and clinic-based where RDTs are currently being used, and particularly for marginalized populations. Next slide. And just to give thanks to the many members of the guidelines development groups and colleagues from WHO at headquarters and in the regions. Thank you.
Thank you so much, Philippa, for that great overview of the new recommendations and guidance that are obviously very, very much in line with the theme of today, which is bringing care closer in a decentralized, integrated way and using task sharing, for example. Thanks a lot. We hope that they will be used in countries for implementation, as you have shared as well. Let us now hear from Fumni about the validation of elimination work that WHO is leading. And some of you may know that we have developed criteria for validating elimination in countries in 2021, last year. And those criteria have now, in the last 9 months, been piloted in 7 countries. And that was actually mentioned by Meg and the DG as well. And so I had this question for you, Fumni. How have the countries responded to this piloting of the criteria, and what are the possible challenges or considerations for implementation?
Right. Thank you very much, Nicholas. And to answer your question, I think I will begin by building on the foundation laid by Meg and Philippa. And in the next slide, please. Right. This is a very familiar picture. And the global strategy, can we go back a little bit? The global strategy, the first ever global strategy for viral hepatitis, was endorsed in 2016 by over 190 countries. And the targets for impact and programs were established to reduce by 90% and 65% respectively. The elimination has been defined, and in the past 6 years, significant progress has been made, as shown in these slides. One of the major ones was reaching a major global milestone for hepatitis B transmission in children, and the SDG target has been met in 2020. Also, the number of people who have received hepatitis C treatment have increased to almost 10 million, reversing the trend of increasing mortality for the first time ever. So we have learned lessons on the graph on the right. We've learned lessons on how to reach elimination from different regions, including the importance of political leadership, price negotiation in Brazil, integrated care within primary health care in Georgia, inclusion of viral hepatitis and health benefits in Australia, and mass screening and decentralization in Rwanda and Egypt. Yet, despite these achievements, new infections continue to occur. Deaths continue to occur. And till date, less than 10% of hepatitis B or 21% of hepatitis C have access to care. Next slide. In the face of all these successes, there comes a question. So how do we measure success? How do we recognize progress? How do we reward elimination? Hence came the criteria for country validation of viral hepatitis elimination. This is the first framework which provides country guidance for elimination of both hepatitis B and C. It provides the what to measure and also how to measure. And it provides the milestones for new infections from hepatitis B, including preventing mother-to-child transmission, and hepatitis C, including in different populations. This framework measures death from liver cancer and liver disease and will help us to track the progress made by countries. So it's a global framework developed by WHO in global consultation with experts and country representatives, and of course, scientific evidence. And its guiding principles are to be country-led and motivate countries to scale up a public health response. Next slide. So this is the framework. It looks a little complicated. And of course, it's definitely one of WHO's mandate and leadership roles in promoting hepatitis elimination. And the criteria, we have the criteria for the impact of hepatitis B and C and for what the programs should measure. And just to give a small example, in some of the programmatic targets, for example, for vaccination, saying that 9 out of every 10 children must receive hepatitis B vaccination, 9 out of 10 really should have access to hepatitis B burst dose. So reaching this criteria require a massive scale up. And the criteria requires the impact and the program and implementation considerations. Next slide. So we set out to find out, are these elimination criteria, are they feasible? Are they acceptable? And that is why we carried out these country pilots for assessing these criteria in 7 countries as shown in this graph. The objectives were 5-fold, as you have seen, and the methods include the development of the tool for assessment and desk review. We interviewed people in the 7 countries and we had consultation and feedback from them. And it gave us an opportunity to explore what the countries have and what we need to go to determine if these criteria are feasible. Next slide. So the results are very encouraging. We found that no one single country has attained all the milestones, but the pilots reinforce our goals that elimination efforts are feasible, they are acceptable, and they can be measured within different country contexts and disease burdens. And of course, reaching these targets require massive scale up that can only bring care closer to the communities and the individuals. Some of the findings are shown on this slide. We looked at PMTCT, hepatitis B PMTCT, which is progressing very well towards elimination of mother-to-child transmission with great opportunities. But we note that gaps persist in implementing hepatitis B birth dose and antenatal testing of pregnant women. Some of the main challenges we found were in the assessment of new hepatitis infections and the need for scaling up hepatitis B and C services and measuring liver-related outcomes. Of course, we found a lot of opportunities for strengthening the data and information system. Next slide, please. So I just want to highlight a summary of the key findings and considerations for implementation from this pilot. We saw clearly that there's need for an intermediate milestone and a tiered path to elimination for high burden countries. This has been done in PMTCT of HIV and syphilis. We found also that there's a need for governance process with the appropriate expertise and manpower at every level of the system. We need to strengthen health data systems to enhance our program data and use all the available means, including modeling, to promote complementary measurements. And of course, finally, to standardize the tools for the measurement. Next slide. So in terms of next steps for WHO and countries, so our next step in the next few months is to establish this set of criteria for path to elimination, or the intermediate criteria for high burden countries. And shown on the right are 3 medals: gold, silver, and bronze. And I think the strong message is that hepatitis is maybe entering into the league of diseases like polio that can be eliminated. So we're looking out for countries to attain elimination so that they can be rewarded and celebrated, and so that a certificate of elimination can be issued to countries who have been able to scale up services, reach these targets, and begin to reach every community with the services that people require. So we are going to revise and update the interim guidance for country validation, finalize tools, and of course, we are available to support countries that are planning towards elimination. Next slide. I think that is the last slide. And on that note, I say thank you very much and hand back over to Nicholas. Thank you, Nicholas.
Thank you so much. For me, I love how it seems a quite technical piece sometimes, but you talk with such passion about it. And I really join you in that passion, in the sense that we all believe if really we find countries that make that incredible progress towards elimination and we can validate for them, it will set a great symbol, and it will really motivate maybe other countries that have made great progress or started progress. And we are very, very proud now to move into the second part of this first session, which is really a very important session, where we will hear from 3 people with lived experience that you can see already on the screen. Lived experience with living with viral hepatitis B or C. And those 3 speakers are as well very strong advocates for viral hepatitis public health. And in fact, I think we know that now there's no public health without involvement and a central role of people who live with a specific disease, as we've learned from HIV and many other disease areas. And so it's a real honor to welcome Thomas, Rachel, and Ibrahima, who will share those experiences with us today in this wonderful session. So Thomas too will be the first one. He's a president of the Australian Centre for Hepatitis Virology. Rachel Halford, Chief Executive Officer of the Hepatitis C Trust in the United Kingdom, and Ibrahima Guillet, who's a founding president of the Association Safra Hepatitis, a patient association in Senegal in West Africa. So I hand back over to you, Fumni, to introduce the first speaker.
Nicholas, thank you very much. I just noted, it's very exciting that we have somebody from Australia, and we have another person from UK, and then we have somebody from Africa, which sort of tells you that hepatitis is not restricted to a particular region, but it's all over the world. And World Hepatitis Day is really a day to hear from people with lived experience. So I'm going to call Thomas. Thomas, we're keen to hear from you about your lived experience. How did you feel when you were diagnosed? And what were the barriers and challenges that you encountered accessing care? So we were looking forward for you to share this experience with the whole world. And
thank you, Dr. Leslie, and thank you for inviting me to provide my perspective on hepatitis B. So I want to start with saying about my diagnosis. Thank you for the question. When I was 15, I was diagnosed with hepatitis B. Like many others, I got it from my mother during birth. That diagnosis was very overwhelming, emotionally overwhelming. I was told I'd have it for the rest of my life, that there was no cure for me. I was not eligible for treatment, and that was highly infectious to other people. I only knew it as a sexually transmitted disease or something associated with being unclean. So as a sort of shy 15-year-old with a migrant background who got raised to be head down, work hard, don't make waves, try to integrate and just be a model migrant, I did like many others do, and was ashamed and kept silent. Like many others with Hep B, I felt alone, disoriented, uninformed, and really more comfortable with not engaging in it at all. It was something that set me apart from society, that embarrassed me, and I wasn't really encouraged to follow up on it. So I just ignored it and forgot about it. And I think this is a key barrier to care. This distance set up by stigma, by fear, by isolation. And it has an impact. Without treatment, without engagement, 25 to 40% of people with HIV will die because of that disease. It wasn't until later during university did I start thinking about it again. Well, I was lucky enough to do molecular biology and ended up doing a PhD in hepatitis B. And now I run my own research group studying how Hep B causes cancer, developing new approaches to try to cure the infection. And it's during these focused studies that I learned many things for the first time that maybe everyone with hepatitis B should know. For example, that it drives this increased risk of liver cancer, 100-fold increased risk. That the first symptoms of Hep B may be due to liver failure or liver cancer when it's too late to do anything about it. I found out we had very effective, cheap, and safe antiviral treatments, but these weren't prescribed unless certain parameters were met, and that hundreds of cures were being developed at the moment. And I think we're doing really badly if you need a uni degree to realize many of these points. A couple of years ago, I made the decision to come forward and publicly announce that I live with Hep B. I did this because I felt a sense of relief and belonging when I saw a couple of colleagues do this, namely Dr. Sue Wang and Joan Block. And I wanted to pay this feeling forward. When I did so, there was this immediate flood of emails in my inbox, people living with Hep B who got in touch and were so honest and so open with their questions, many saying that they were sharing their diagnosis with someone for the first time. Many of these stories repeated and rhymed in their themes. And this was independent of whichever country they lived in. There was loneliness, self-imposed isolation, not understanding what lab results mean, and confusion how to go about their lives with this condition. Everyone had similar stories and similar problems, but like me, for the first half of my life, they were staying quiet and not talking to anyone about it. And so the barriers to communication were not only between these different communities, but even in the same community, all these people with Hep B not talking to one another and suffering because of it. So to get people talking to one another, I set up an online forum called hepbcommunity.org. We have scientists and clinicians asking people's questions, but more importantly, it's a safe space for people with hepatitis B to connect with one another and share their experiences. We really hope to spread the awareness of our community and help more people during that really vulnerable time when they've just been diagnosed and they're seeking more trustworthy information, advice, and experience. And nothing garners more trust than people you know have been through the same thing and walked through your shoes. There's one question that isn't usually explicitly asked, but you can see it sitting there between the lines in people's stories. And to me, that's one of the key questions, and it answers one of the biggest impacts on people living with Hep B and our global response to it. The question is, am I alone in facing this? The goal of Hep B community.org and my work in general is to be able to truthfully tell everyone with Hep B, no, you're not alone. And I hope you all will join us in this goal. Thank you.
Thank you very much, Thomas, for sharing this very compelling story. Hepatitis. Indeed, you are a star, you're a model, and you are an inspiration to all of us. And we hope that the compelling story will strengthen the hepatitis community and activate the collective voice to make a global impact for elimination. So thank you very much again. And I'll call now our second speaker, who is Rachel, the CEO of Hepatitis Trust from UK. And again, Rachel, I would ask you to maybe share with us your lived experience. I know you have hepatitis C. Can you tell us how you felt when you were diagnosed, and what were the kind of challenges that you had in Europe? You know, how did you access care, and how has this impacted your outlook? So, Rachel, over to you. Thank you.
Thank you, Fumi, and thank you, Thomas. It was a privilege to listen to you. I'm really happy to be here today on World Hepatitis Day. It's a really important day for us. My story's a lot, I was diagnosed a long time ago and a lot of things have changed, but being diagnosed and the feelings that came with that, I think are probably very similar, or I know are very similar for people today. So I was diagnosed with hepatitis C in 1998. So that's when after 20 years, I stopped using drugs. And at that time, I knew a very small amount about hepatitis C, but only that it was a consequence of the lifestyle that I'd been involved in. And when I actually went and got tested, my only concern at the time was, did I have HIV? Because I knew more about HIV. And when the nurse came out and she gave me my diagnosis, she said, you don't have HIV, but you do have hepatitis C, but don't worry about it. You'll die of something else before you die, before the hep C will kill you. And then that was it. And she walked away. And really, I had one other appointment that was sent to me in a hospital, which was many miles away, to do a biopsy on my liver, which no one explained to me how painful it was going to be, and to do the genotyping. And then that was it. I heard from nobody at all until 2007. And that's actually a really long time to not hear anything and to have nothing followed up. I'm conscious today that it was a very different environment at that time, but I think it's really important, the point within that is how important it is to, for somebody to be told what's happening next. And there's that follow-up. So, but kind of over those years, irrespective of the fact that I knew a few people that had hepatitis C, when I walked away from my friends and I was kind of living my day-to-day life, hepatitis C carries so much shame and stigma. So there's a shame of the lifestyle that I'd come from, and then there's a stigma that comes from that and from the hepatitis C. There was a lack of understanding from people around me, even within my own family. Even though I explained it, my family were, really frightened by my diagnosis. And with my children, I was really conscious of the fact that, I had to be really careful. I know that hepatitis C is difficult to catch, but it became quite obsessive, blood to blood, make sure no one's using my toothbrushes. And then in the UK, if you made a dentist appointment, I always had to go on the end of the list because the dentist was concerned that I would, give hepatitis C to somebody else. So constantly there was this reminder that, I think Thomas said it as well, that I was dirty, that there was something about me that was, just dirty. And it's a really horrible feeling to carry, whether it's a consequence of a lifestyle or it's something that's born to you. It's a really horrible thing to live through. And I guess because I just wanted to add on there that during those years also physically I became really strangely unwell. You know, I had lots of weird side effects which I didn't know whether they were to do with the hep C, a lot of brain fog. I had issues with my stomach, my legs used to swell up, and because I had no contact from hospitals, I had no understanding as to whether this was to do with the hepatitis C. But anyway, in 2007 I did complete the interferon treatment, which if anybody out there knows, I did interferon ribavirin. You know, it cleared my virus, which was amazing, but it was a really nasty treatment and had an awful impact on not only my body but my mind. You know, and thankfully today, you know, when I sit here and I share my story, that isn't the case in treatment today. You know, there is open access to treatment, you know, for anybody. Access if you've got it in your country, but there is treatment available for everybody if you can get it in your country. And I think that, you know, my experience, it really greatly impacted my work moving forward. You know, I think that, you know, what we know is that people who use drugs, or people who a majority of them kind of sit outside the norms of society, in particular health. You don't engage in health systems. You know, and what we know about hepatitis C is that more than 90% of people affected by hepatitis C are people who have or do use drugs. You know, and I think that what's really important here, and this is about equality of access as well, is that we need to take the services to them. We need to integrate them into the services that they may access, you know, whether that's a pharmacy for needle exchange or something, or go out on the streets, you know, go out in outreach vans, you know, and listening to Thomas there, that, you know, I totally agree, you know, that the power of the peer, because one of the most effective ways to reach this and to do this is by using peers, people with lived experience. So not only do you have the shame, but I think with people, when you're working with people who use drugs, who, you know, they can be very difficult to engage. There is a lot of suspicion about other services. That we still hear today, that people don't know that there's new treatment. They think it's still the old treatment, so there's a lot of fear. So peers, people with lived experience, have a crucial role to reach elimination, deliver services, and lobby government powerful. We are needed to get our not only to support each other, but also to raise the message and to raise awareness with the general public and with our governments, etc. So my role today is I lead the Hepatitis C Trust, and we are an organisation that employs people with lived experience. And we're really fortunate to have more than 120 staff and 160 volunteers, all who have lived experience. And we are actually a key stakeholder within the UK National Hepatitis work stream. We work alongside NHS England, we work alongside clinicians, and we work, and actually this is just having the patient at the centre, having the peers at the centre, having the voice at the centre is incredibly important. And it really supports, I guess, like I'm saying, reaching those people. Through our work, we have peers at the centre of identifying and supporting people affected by hepatitis C. And it happens immediately. There's no 9-year wait like there was for me. They can be contacted straight away. A peer can explain what's going to happen next, or can explain their options of what can happen next. There's no long-winded journey to many different departments in huge hospitals. We can support patients to navigate the system, and where possible, the shortest pathway. So we work in prisons, and prisons are an incredible place to actually reach people who often sit outside healthcare systems. You know, and just since 2019, we have tested over 30,000 people in prisons through our peer work. We've also tested and supported through outreach out on vans over 10,000 people through their treatment journey. And in just 1 year, we've tested just under 20,000 people through community outreach. I know that I'm waffling on a little bit, and I'm going to stop because I just think there's so much information to share, and I'm just so passionate about patients and peers, you know, whether it's hepatitis B, hepatitis C, the identification to support others and then to raise awareness and engage the general public to go and get tested. I think we heard it earlier that there are still people who aren't aware that they've got hepatitis C. There's an awful lot of people. We do need to raise awareness. And if we're going to achieve elimination, stop people dying, because people are dying, we have to work in partnership, collaborate with the patient, decentralize the services and take the care to them.
Thank you, Rachel. You're such an inspiration as well. And the work that you're doing is just amazing. And thanks for sharing as well your personal stories, the experience of stigma and other marginalizations, and shared as well by Thomas. It is really, I think the good news is that there is a cure now for hepatitis, and that unfortunately it's not accessible everywhere in the world like it is, for example, in the United Kingdom, but we will all work together to make that access even better. So we will now switch to French for the next 5 minutes or so. So please, for those who need interpretation, there's a globe in the Zoom platform. You can get interpretation to French. Je vais maintenant changer pour environ 5 minutes.
Switch into French for a few minutes. That's because we're going to warmly welcome Ibrahim Igwe from Senegal. Good afternoon, Ibrahim. We're delighted to have you here with us today. You're going to be our third person who's going to be sharing their personal lived experience of viral hepatitis with us. You've been living with hepatitis B, as I understand it, so thank you. Please, could you explain how you were diagnosed and the challenges that you faced in accessing care in Senegal, which is your home country? So thanks once again for joining us, Ibrahim. Good afternoon, Dr. Nicholas and Dr. Leslie and all panelists. I'm Ibrahim from Senegal. I'm the president of the Association Safara Hepatite, and I'm also on the board of another association. I was born in '64, and very early on I was infected by hepatitis B without being aware of this. For many years I was unaware of this, and it was only in 2010, in fact, that I truly understood that I was infected with this. This illness showed that I was indeed Hep B positive and infected with another illness. This was the start of a long combat, a long fight. It has been very hard for me. Quite simply, I needed very frequent doctor's checkups, but the healthcare wasn't very good. The checkups were frequent and very expensive. And I suffered extremely strong side effects from the treatment that I was taking for a very long time. I treated myself with traditional medicine, and so I used this traditional medicine because my illness was confused with yellow fever and malaria. Thankfully, in the end, despite all the money that I spent and despite the difficult path, I also had several operations first, and then I had a second operation with a liver graft. This was very challenging, but as I said, I was diagnosed very late, and this created significant problems, and I had to spend so much money. Today, however, I'm very grateful. Thank God, after the liver graft, I tested negative to one specific type of the illness. In other words, I tested negative to Hep B, and I no longer have this illness. Right now, I'm being vaccinated for Hep B to ensure that I have full coverage and immunity. So that's an overview of the challenges that I face, but allow me to say that today I am a happy man, but I'm not yet fully satisfied, because as we're talking about viral hepatitis today, we cannot wait. Indeed, we cannot let hepatitis continue to kill people, to kill young people, people who are unaware because they don't yet know whether they are positive or not. And so today, I'd like to say quite clearly, we need population groups to be diagnosed very early on to avoid any future complications. We have to think about vaccinating children, in particular in Africa. The reality is that there are very few African countries which vaccinate children at birth. The majority of countries don't do this. So we really need to do more. The WHO and the World Hepatitis Alliance needs to ensure that these countries can roll out vaccination at birth. Today, we need to ensure that there's availability within our healthcare centers, all diagnosis and treatments available. If we want to eliminate hepatitis by 2030, we need to work swiftly. We can no longer wait. And thus, we call upon the WHO and the World Hepatitis Alliance to do everything that they can to ensure that countries can have a robust national hepatitis programs. Without these robust hepatitis programs, national programs, people will continue to suffer. So that's what I'd really like to stress. Thank you very much.
Thank you very much, Ibrahim, for your statement, for your story, and for your recommendations on what can be improved upon in countries worldwide. For example, in your region. Thank you very much once again.
To English. It was a great pleasure to have someone as well speaking in French language about their personal stories. And we will end the first session. Thank you again, Fumi, for all those great talks and insightful stories from our three panelists on their lived experiences. Absolutely fantastic. We will now move swiftly, because we're already a little bit behind in time, to session 2 with a very fantastic range of different partners and panelists and friends and guests that we will have there. This part 2 will be a facilitated panel discussion showcasing opportunities, challenges, and solutions in bringing care closer to you. Most importantly, it will be co-moderated by our colleague Diana Fani. Diana joined us a few months ago, and she leads the strategic information work in viral hepatitis at the HQ in Geneva, and we can see her. She's joining from the United States, I believe. It is wonderful to moderate that with you, Diana, and please go ahead.
Thank you, Nicholas. And without further ado, would like to share with you a poll that we would like all our participants today to be able to participate. So Romina, if you could please, or Rosalind, please share the slide with the word cloud poll for our participants to participate. Thank you. Would like to draw audience attention to the poll. You can access it through the link provided in the chat, as well as by scanning this QR code. What we would like you to do is answer the question in the poll that asks you to describe in 1 or 3 words what bringing hepatitis care closer to you mean. And we will be able to see the word cloud being generated from your responses directly through this screen. So please access the question through the chat, the link provided in the chat, as well as in the QR code. Thank you very much. It's good to see the words coming up. And I see equity is the most featured description so far. Thank you very much for all those who are participating, and we'll give it another few seconds before we start the panel discussion. Thank you all. So equity, health, awareness, villages. See, I believe people want to have hepatitis testing very close to their areas. Thank you so much. Please keep on participating in the poll, and towards the end of our sessions today, we'll share the final word cloud generated from what you have shared with us to understand better what bringing hepatitis care closer to you would mean to everyone participating in this webinar. I'll now go ahead and introduce our panelists for the discussion today, and if I could ask them to please put on their cameras and their videos so that we could see them as we introduce them. Rosalind, if I could ask you to please share the slide with our panelists. Thank you all. So for our panel discussion today, we will have with us Dr. Justin Kunin, who is the co-chair for the UHC 2030. We also have with us Mr. Danjuma Ada, the president of the World Hepatitis Alliance, Dr. Sanjay Kabra, who is the head of the National Viral Hepatitis Control in India, Dr. Muhammad Abu Hassan from the Ministry of Health in Malaysia, Dr. Lee Abdelfadel, who is the Senior HIV Advisor at the Global Fund, and Dr. Finn Rod, the Executive Director for the Hepatitis Fund. Thank you all for joining us. And I think I would want to start with Mr. Danjuma. We have had earlier today from the 3 patients who shared with us the stories, Ibrahima, Rachel, and Thomas, on how it is very key to have peers as part of the discussions towards the elimination of viral hepatitis. And perhaps I could ask you, how is the World Hepatitis Alliance supporting the global hepatitis response? And what is the role of the WHO in bringing people who live with viral hepatitis and the affected communities closer to prevention and care services?
All right, thank you so much. And we sincerely thank the World Health Organization for putting up this event. And thank you to all the great panelists that have talked earlier. So the World Hepatitis Alliance, we are literally the face behind hepatitis. Behind all the numbers that you have are people that are living with hepatitis, and we represent the community. So the World Hepatitis Alliance have supported the global response over the years by leading efforts and collaborating with partners like the World Health Organization. In fact, even to recognize the World Hepatitis Day as a global event to be recognized and celebrated globally. We've actually helped and brought combating viral hepatitis in the SDG and also in the United Nations political declaration, where in the context of universal health coverage. Now, listening to the stories earlier on goes to tell you that if you look at the Alma Ata Mater, that talks about nothing for us without us. So as a community and people living with hepatitis, it is important that the community are at the heart of the response. Rachel did mention her story about peer support, which is very crucial in breaking barriers to access, breaking barriers to care that we need to really bring to scale. You need peer support and you need people with hepatitis and the affected populations to drive this. I'm glad that the new global health sector strategy for viral hepatitis elimination that the WHO recently adopted once again looks at the people-centered approach to elimination of hepatitis. And that puts the affected population at the center and the heart of the response. Now, it is very important to look at the role of the community. As a community, as the people living hepatitis, we will support this response by creating the platform for peer support, reduce stigma, creating a platform for driving community-driven interventions that will bring about ownership in the community and will break down the barriers to ensure people access the care that they need. Now, what is most important again is the cost of inaction. I think it's important to remind us all that there's catastrophic cost of inaction if countries and policymakers do not take action in hepatitis elimination. So to round up, I would say that putting people, affected populations at the heart of the response is very crucial towards hepatitis elimination. It takes us to tell what it means and how stigma affects us, how stigma reduces people's access to care. And that's why it's important to have affected populations drive community-driven interventions so as to have more ownership and to drive sustainability. So thank you to the World Health Organization, and we at the World Health Hepatitis Alliance are ever ready to support the people-centered approach towards elimination of hepatitis. And we call on governments and partners to ensure that communities and affected populations are at the heart and center of the response so that it becomes more sustainable and we're able to break down the barriers at the community level for people to access the care that they need. Thank you, and over from you.
Thank you very much, Danjuma. And it's really great to hear your reflection, because it is important that, that we hear the voices of the 350 million people living with hepatitis so that they're featured within the discussions towards elimination of viral hepatitis. Thank you very much. Our next panelist is Sandia Cabra. And, in reflecting with what the DG had mentioned in the video today, is that we do need that hepatitis care testing and treatment provided within communities where people are. And for that, we'd like to hear from Dr. Cabra how India has been building on the viral hepatitis response through the lens of universal health coverage, and would like to hear her share India's success lesson learned from the national approach and how we can bring hepatitis service care closer to people.
Good evening, ladies and gentlemen. At the outset, I would like to thank WHO for giving India an opportunity to highlight the country's viral hepatitis response through the lens of universal health coverage. Considering the magnitude of the problem, and in line with the SDG Target 3.3 to combat hepatitis, India launched the National Viral Hepatitis Control Program through the existing health systems. Under the umbrella of universal health coverage, India has ensured access across the country with focus on priority groups by identifying appropriate interventions, addressing quality using standardized training and provisioning for quality commodities, and ensuring 100% domestic funding for sustainability. India is a federal country with 36 states and union territories. Each state is divided into multiple districts which serve as administrative units where decentralized health services are available through district hospitals, community health centers, primary health centers, and health and wellness centers. Strong political commitment, integrated services, and flexibility which promote innovative approaches are the hallmark of the program. The program provisions for free drugs, diagnostics, capacity building, and prevention measures. The program has also leveraged on the existing established mechanisms for for healthcare delivery amongst pregnant women, identified high-risk groups under the AIDS control program, blood transfusion services, and dialysis services. Utilization of resources at all levels of health systems in terms of infrastructure, including equipment, trained human resource, and established mechanisms of diagnostics and treatment services have optimized service delivery with financial efficiencies. We are in the process of integrating with the National AIDS Control Program. In this program, we propose to promote screening in high-risk groups for hepatitis B and hepatitis C and linking those screened positive for management. We are also provisioning for hepatitis B vaccine to high-risk groups screened negative for HPV infection. The program has integrated with Reproductive Health Division for universal screening of hepatitis B in pregnant women to ensure institutional delivery and administration of hepatitis B immunoglobulin along with birth dose of hepatitis B to newborns of those screened positive within 24 hours of birth. We also promote referral services to donors screened positive in blood banking and patients undergoing dialysis. We also provide for vaccination against hepatitis B to the healthcare workers in ongoing collaboration with immunization program. Efforts are now being made to scale up the services to include correctional homes, rehabilitation and de-addiction centers, and reaching out till the last healthcare facility established at the health and wellness centers to bring hepatitis services and care closer to people. Involvement of infected and affected populations and civil society organizations in policy, planning, and implementation have contributed significantly in successfully rolling out the program in the country. I would like to conclude by highlighting the lessons learned during the journey of program implementation. Utilization of the health systems approach, delivery of sustainable quality services using domestic funding, leveraging on existing programs and infrastructure to avoid duplication of resources has been rewarding and has resulted in scale up of services across the country. Thank you very much.
We appreciate a lot to Dr. Kabra to have shared this video with us. Ibrahima, can you please mute yourself or someone mute your, if you can't do it from the central. We again appreciate Dr. Kabra. She can't join today because they have very big World Hepatitis Day events in India that she had to join, and that will be very important for the country progress. I think this is an amazing presentation that somehow exemplifies really some of the core principles of our new global health sector strategy that has been highlighted by Fumni and Dr. McDoherty, which is really the coordinated approach in a UHC and primary healthcare framework, integration with HIV, focus on marginalized at-risk populations and highly affected people, including prisons and so forth and so forth. Very, very impressive framing, and we hope to see much more or continuous progress, in India in the many next years, which is important and big country that we need for elimination as many others. We will now turn our ears and eyes to Malaysia, and we welcome Dr. Abu Hassan. Dr. Abu Hassan, I will go directly to the question. Many of us know already that Malaysia has really championed the decentralization and integration of hepatitis C care into primary care and other service platforms. And we wanted to hear from you, what are the key lessons that you learned and that could be shared with other countries? And is there any plans in Malaysia to extend this approach to other populations or other service platforms, or from hepatitis C further to hepatitis B? The floor is yours, Dr. Hassan.
Thank you very much, Nicholas. Well, decentralization has been our key strategy in Malaysia. I would like to share, why decentralization seems to be quite a successful strategy in Malaysia. I think the first reason is mainly because of the fact that the the facilities, the one that we have, i.e. we have a quite widespread healthcare facilities across the country. Well, it's been, let's say, about every 5 kilometers, at least there will be a form of healthcare facilities in Malaysia. So we are busy riding on this infrastructure by providing tests and treatment for the hepatitis C across the health facility in Malaysia. So this is one of the major advantages that we have currently. The second reason is that because of we have a massive support from our government of Malaysia in terms of providing a free service, free DAA, as well as the laboratory support. So given these two factors, I think we have liberated the decentralization in Malaysia quite successfully. But having said that, I mean, well, the initial stage was quite easy because most of the patients, the one that we have, they are all basically have been linked to our healthcare facilities. And majority of them are the people who use drug or the methadone therapy who are already linked to the health facilities. So it's quite easy to treat at the initial stage. Now we realize that, I mean, there are a lot more in the community, which I think this is probably, I think, been seen in many countries in the world as well, whereby we have to reach out, especially those in the community. For some reason, they are not coming forward, despite of the facilities, the one that we have at the healthcare facilities, as also with the free treatment that is available. So there are a few measures, the one that we have tried so far. And I must say that I'm very excited to share some of those measures that we have ventured in. The first one I would like to mention about the one-stop center or one-shop center. This is quite popular, especially among the people who use drug, because I think mainly because of the convenience and also because of the reduce their visit to the healthcare center. So it's been very popular. So we're trying as much as possible, especially to reach out the people who inject drug, who are still out there, but still not coming forward. But I think we try to reach them out by providing this kind of service, and as much as possible, so trying to reach out them through the community services by providing what we call this the one-stop center or one-shop center. The second one, which we had just started this year, is actually providing the access treatment, start screening the prisoner. We have tried that before, the COVID-19, but it was somehow rather fail, I think, to a certain extent because of the logistic problems, so on and so forth. So we have learned from that. So what we are doing right now is that we are coming into the prison, helping out the allied people in the prisons, and then providing the screening. We screen all the new prisoner, riding on the existing screening tests for the prisoners who been admitted to the prison. So currently we have what we call this screening for the TB as well as for the HIV. So what we do is we add on hepatitis C as well on top of this regime, and we actually test and also do the reflect testing straight away, i.e. taking the checking for the viremia and get them treated once if they are positive. So this is very exciting. I mean, it's something which is very rewarding because I can see there are a lot of patients of prisoner inmates has been diagnosed and treated as such. The next one that we are trying to do right now is that trying to do the outreach program, particularly in an area whereby there are been observed to have a higher incidence or prevalence of hepatitis C. We have observed that especially certain area, fishing village, for some reasons, I think they are also involved with substance abuse to a certain extent. And we are targeting certain area, fishing village, certain settlement area to reach out to them, do this test and screening, i.e. we go to the community in order to reach out to them. The next one, which we are also quite excited about it, is that we're trying to do the get those who are in the rehabilitation center. So this is also doing very, very well at the moment, whereby the people at the rehabilitation center has been trained to test and treat all those patients with hepatitis C in there. Our next move, which this is also another very exciting, that we are doing it together with the international organizations, for example, the MSF. So we have started doing the collaborations with MSF to treat the refugees. So among the Rohingya refugees, so we have started that somewhere up north in peninsula of Malaysia, one of the center in Penang, where we have started treating the refugees among the Rohingya. The last strategy which I would like to share will be that we also venturing into what we call the digital technology, whereby we're trying to get the self-testing through the digital platform, i.e. Particularly I think among the group MSM people, this is quite popular. This is a platform whereby we share or piggyback on the HIV platforms for the self-testing as well. So we are using the same platform also for the hepatitis C. And the main clients mainly will be the MSM. And this is also very exciting because we are getting a very good response from the, or uptake from the this particular group, because being MSM is quite a huge stigma in Malaysia. And I feel that I'm quite optimistic that this the continuous effort and the work that we have been doing, I think we should be able to reach out to as many as possible hepatitis C patients out there. And then we are also planning towards emulating this strategy for the hepatitis B as well. Of course, I think these are two different diseases. So, I mean, they are different in terms of the treatment, basically. So it's a bit more complex as compared to the hepatitis C. So what we're trying to do now is that we are upscaling our effort in the MTCT, mother-to-child transmissions, but at the same time also we're trying to also treat what we call this the hepatitis B at the periphery as well. So we're starting doing the training, and there's a few event sessions to get our primary healthcare to also sharing the burden of treating the hepatitis B patients. So I think that's mainly, if I can just summarize, I think there are many, I think that's mainly what I'm going to share on hepatitis C.
Thank you so much, Dr. Abu Hassan, for joining us and highlighting your principles for decentralization, but as well a lot of innovations that you shared, such as self-testing, further outreach, and reaching very vulnerable refugee populations and moving into hepatitis B. Fantastic work in Malaysia that is so nice to hear about. Thanks again. And we will now move to the last three speakers. The next one is Dr. Justin Kunin. He is a co-chair of the UHC 2030, as we have heard already. Thanks for joining, Dr. Kunin. And we have heard now quite a lot from countries and communities and people with lived experiences, and even from WHO, what are the principles to bringing hepatitis closer to communities. And we've heard a lot about universal health coverage, you know, in many of our talks. You are really working a lot in this area. And can you share with us from your perspective how countries can better understand this framework and of UHC and as well primary healthcare, PHC, and how can we strengthen the national hepatitis response within this framework according to you? Thanks, Justin, for joining us and share your answers.
Thanks so much, Nicholas, and hi, everyone. Let me start with those really touching personal stories, because I think what they emphasize is the central importance of integrated person-centered care. And that's something that Dr. Tedros also mentioned in his introduction. Because when a person presents themselves to a health service, they don't want to be compartmentalized or separated into the part that needs hepatitis treatment over here, the part that's concerned about NCDs over there, the part that's concerned about mental health somewhere else. They're a whole person and they want to be seen as a whole person. And so if health coverage is to be truly universal, we need to see a shift from health systems designed around diseases and health institutions towards health systems designed for people. And so when we talk about universal health coverage, we mean creating systems such that all people have access to the health services they need when and where they need them without financial hardship. And that means access, importantly, to the full continuum of health promotion, prevention, treatment, rehabilitation, and palliative services. And naturally, that means that hepatitis needs to be incorporated into national priority health benefit packages. The challenge is how we build these systems in an integrated way. And I think we've heard great insights into what's worked in India and Malaysia from Dr. Kabra and Dr. Hassan. And the key lever we have is through strengthening health systems with a focus on primary healthcare, because it's PHC which will enable the delivery of services as close as possible to people's everyday environment. It's PHC which will give the best bang for your buck, so to speak, financially in these extremely resource-constrained times. And it's PHC which can provide the platform to address multimorbidity where it's feasible and appropriate. And so what this requires then is the strengthening of the primary healthcare infrastructure. That means adequate numbers of well-trained, well-paid healthcare workers. It means empowering communities so that they have a say in decision-making about their health needs. It means a coordinated approach to public financing for health, to data systems, to supply chains. And critically, I was really pleased to see this in the word cloud from our participants earlier. It means a renewed focus on equity so that we reach and protect the most vulnerable population groups. I think it's one of the most misunderstood aspects of UHC, particularly from communities who've spent so long building specialized interventions for key populations. Those specialized interventions need to stay. We must integrate where it's feasible and appropriate, but we must also maintain differentiation of services where that is important. I said earlier that there can be no true UHC without making progress on viral hepatitis, but the converse is also true. We can't achieve the goals we've set around hepatitis without UHC and PHC, because without them, we won't have the health systems we need to deliver the interventions we want. Thank you very much and have a most meaningful World Hepatitis Day.
Thank you very much, Dr. Justin, for your remarks. And certainly it's good to see how our theme for today, that is bringing hepatitis care closer to you, certainly means stronger primary healthcare systems and where services are integrated and provided at places where people live. Thank you very much. And I'd like, again, at this point, to thank all our panelists. We've had good presentation from the civil society representatives, as well as from the ministries of health from Malaysia and India. And now I would like to turn this discussion to welcome our panelists from international partners on how building stronger hepatitis responses can be achieved through various mechanisms of funding. And would like to hear first from Dr. Lee Abdelfadel from the Global Fund, and to reflect on what the Global Fund has done in HIV, TB, and malaria. And we do acknowledge that the Global Fund has made very remarkable catalytic contribution in the past, targeting on viral hepatitis as a way to eliminate viral hepatitis as a HIV co-infection. And Dr. Lee, could you please tell us about the new strategy from the Global Fund and how this is focused on the action for viral hepatitis?
Good afternoon, everyone. I hope you can hear me well. Thank you for having me as part of this esteemed panel in celebration of our joint hepatitis efforts. Partners, friends, colleagues, people living with and cured of hepatitis, fierce advocates. Let me start by saying that the Global Fund new strategy for 2023-2028 is called Fighting Pandemics and Building Healthier and More Equitable World. And I think our commitments are very clear in this title. Our strategy is also aligned with the Global AIDS strategy and with the health sector strategy on HIV, viral hepatitis, and STIs. We welcome these global commitments. We subscribe and ascribe to them and all the great work that WHO is doing to lead this agenda. We will seek in our new funding cycle that's starting very soon in 2023 to accelerate a shift from a more siloed intervention approach to a more integrated, person-centered, quality models of prevention, treatment, care, and support. We would like also to really center on expanding the self-care architecture and making sure that the holistic needs of people we serve are met, that they have options, and that includes hepatitis care being closer to them, especially those people who need it the most. You will see these changes not only in our strategy, but in our upcoming HIV information note that will be published in a couple of weeks, and the accompanying guidance note that most of you in this call have seen and heard about around prioritization of supporting health and longevity among people living with HIV. We are encouraging all the Global Fund applicants, all the national programs to consider this guidance as soon as it is published in 8 weeks, as they're also developing their new funding requests for 2023. In this guidance and documents, you will see that we're making commitments to support investments in viral hepatitis, prioritizing a new and expanded scope of investments around hepatitis C, specifically in people who inject and use drugs, and in integrated triple elimination of vertical transmission for HIV, syphilis, and hepatitis B. We are also continuing our previous investments, our previous support in viral hepatitis in general, in prevention, diagnosis, treatment, and care for key populations, adults and girls and young women. That commitment hasn't wavered. So please watch this space as the guidance notes and information notes are published soon. In addition to our investments in HIV and viral hepatitis, if you might say directly, in the resilient sustainable systems for health, where we collectively tackle primary healthcare, UHC, you will also see the system strengthening commitments we're making to integration, to person-centered quality investments across health and community platforms and service delivery. And you will have the ability to choose from them to accompany this prioritized HIV investments. We support and complement the increasing domestic resources exemplified in this panel today by the national investments and effort highlighted by the Honorable Ministry of Health representatives of India and Malaysia. We also understand that the resources are finite. So we urge all of you, the national HIV and hepatitis programs, the health system experts, to consider meticulous and deliberate, precise prioritization as you think through your Global Fund investments and requests. We also acknowledge that, all these prioritized investments are based on need. So they're based on epidemiology, on programmatic data, and on local context as well. And all those start with the national strategic plans for HIV, for hepatitis, for the costed investment case as well. And I know that WHO has collaboratively led great work in this space. So we'd like to work together with all available funding sources, domestic, PEPFAR, bilateral, multilateral resources, and others to appropriately direct resources and investments to prevent and treat viral hepatitis, bring care closer, specifically to key vulnerable populations, and improve health and longevity in people living with HIV. As you know, this year is our replenishment, as you can see by my background. And over the past 20 years, the Global Fund supported programs. All of you has helped us invest over $53 billion and helped us save 44 million lives, reduced combined death rate from HIV, TB, and malaria by half. In this 7th replenishment, the Global Fund needs at least 18 billion. This is the minimum required to get us back on track to end HIV, TB, malaria, build resilient, sustainable systems for health, pandemic preparedness, also address our investments in viral hepatitis, other comorbidities and co-infections, and bring care closer to all of you, all of us. So let's fight for what counts. Thank you, and over to you, Madam Chair.
Thank you for your passionate and fantastic words, Lee. We appreciate so much that you join us for the whole webinar. Montreal is this week, AIDS 2020, the notes, the replenishment. You have a lot on your plate, certainly, and all the HIV community as well. It is fantastic to hear and to collaborate with the Global Fund and to hear that there's now even more clarity and focused investment on viral hepatitis as a co-infection with clear priorities from the Global Fund. And it will be fantastic to collaborate with countries to make some of that happen. Thanks again for joining us and sharing this news. And I think we will all look out for the final notes as they come through in a few weeks. I think if you have the dates, you can put them in the chat maybe so that we can see when we look out for them. So now over to our last speaker before the closing session. That will be short. It is Finn Rode, who is the executive director from the Hepatitis Fund based now in Geneva. Finn, while we recognize, and I think Lee has mentioned it as well, the vital role, especially for viral hepatitis elimination of domestic funding, and we heard from India, we know that this has been crucial in the last years, where progress has made countries really invested themselves. We still think and want to hear from you about the role of catalytic support to the global and country level viral hepatitis elimination response, and the specific perspective of the Hepatitis Fund that you lead. What do you think are the major funding challenges, and share any thoughts about our day-to-day and the webinar from your perspective? Thanks.
No, thank you so much, Nicholas and WHO for inviting us today to be part of this panel, to be part of discussion with the wider community on fundraising for elimination of viral hepatitis. The Hepatitis Fund is the main role is actually, the initial thought was to be that sort of slush fund, to be able to turn around, open calls for proposal and distribute funding locally. I would say in terms of scale and opportunities, we are not there yet, but working very hard to be the, not to be a new global fund, not to be a new Gavi, but to support and discuss with Global Fund and Gavi how we can integrate, as everybody is saying today, how can we better integrate elimination of viral hepatitis B and C, specifically, to enable us to have more funds available to do what we want locally. Because it's like all the speakers today, all the personal stories, all the sort of thinking around viral hepatitis is amazing. You know, we have all the technical capacity, we have all the opportunities to reach this target under SDG 3, but we are actually failing to reach that today with the speed that we have today. And mainly that is because we are lacking funding. And why? Because maybe we are lacking fundraising skills. So I'm not blaming anybody. Then my myself and my organizations to initiate that, to come forward, to talk with possible donors in country, in region, globally, to have that opportunity. And I think that exactly what you are asking me, why is today we are unfortunately, I would say, let's say that's my personal message, we are too silent. We need more activism. We need more advocacy. We need more campaigning, and we need to showcase the results better than what we are doing today. These 4 initiatives will raise more funds. Number 5 is then that we need to be more professional in fundraising. We need to come forward to government, to institutional donors, to multilaterals, to high net worth individuals, family and private foundation. We need to have a dialogue that highlights what we have been doing so far in the course of elimination of viral hepatitis and what we want to do to actually reach that goal in or targets in 2030. And I think this, you know, all the cases are there, all the studies are there, all the sort of technical statistical information are there, but it's for some reason we lose out to other diseases. We know that health activities and initiatives in any country are possibly the most expensive thing that a government can focus on. So we know that that is very strict prioritizing from any government to be able to reach universal health coverage, to reach elimination of viral hepatitis. But we have to be in there. We have to be having that local platform, that local foundations that has opened doors to the government in the first place to be able to access decision makers, to enable us to go back locally and be part of primary health care and have actually funding behind that, those initiatives to activities and programming on elimination. And I think to shift the focus then from the negative side and just to endorse all the positive stories today and all the thinking around what we can do, I think it's a parallel run locally, regionally, and globally. We have to run together to do that fundraising. We can't sit in Geneva and do it, but we have to do it together with local organizations as we are working from the Hepatitis Fund today in different parts of the world to work with local government, to work with central government. We see in the champion countries, clearly, there's been a buy-in from the head of states, absolutely with no exemption. We need that door open to be able to lift understanding of what is needed of a government to reach elimination. We need to have that work going together where local organization, local foundation, high net worth individual, and opportunities from international donors to go together and take that enormous initiative that has been, let's say, the last 5-6 years since it came in under SDG as a target. Enormous activities that has been done, but we have to lift to a different level. We have to work with Global Fund. We have to push, activate Gavi to do the birth dose. They are delayed by 3 or 4 years. It's impossible, you know. As was said earlier today, 1.2 million people dying every year. So we can't wait. It's like you all have been saying, we can't wait, but we have to have a more structured, a more strong, activated approach to be able to be part of that sort of global fundraising initiative that should be there also for viral hepatitis to be able to eliminate. We are not there today. I think we are at a funding level which is 1/10 of what is actually needed. So there's a huge gap, but I think that sort of initiative, as Nicholas mentioned, with catalytic funding, with seed funding that goes into country, we see with this specific disease, we can do enormous amounts of cases can be handled with very small amount of money, especially if we follow that sort of integrated approach. But that also means that the big organizations today, the big donors, the sort of large government donors need to continue not only to say we'll break down the silo, but actually doing it, to allow us into that room where opportunities are to find fund for the activities that we want to do. We don't see that today. It's part of my job, it's part of my organization, it's the focus that we have. And we call for all those who are listening today to actually open these doors, to enable us to get the funding that's already there to help support the target elimination of viral hepatitis. Thank you.
Thank you so much, Finn, for your always very thoughtful and stimulating interventions. I would like to thank the panelists, Dr. Kabra, Dr. Abu Hassan, Danjuma, Finn, Justin, Lee. Thank you so much for joining us. And thank you so much, Diana, for co-moderating, joining us from far away. And it was a wonderful session. I hope you agree. And we will immediately move into the closing remarks from Phumni Lesi and then our ADG, Dr. Mingui, who joins us during his leave. Thanks so much, Dr. Ren.
Thank you very much, Nicholas. We are at time already, but just a few brief words as we bring the session to an end. It has been a phenomenal event with over 300 people remaining online till the very end. We thank you all. We thank you all. The shared testimony of people who live with viral hepatitis must compel us to action. And we can see that it has impacted their lives significantly with Rachel and Thomas and Ibrahima working towards hepatitis. Ibrahima has also sent in a text message that as a cancer survivor, he has dedicated the rest of his life to the fight against viral hepatitis. We thank our colleagues from India and Malaysia who are making great strides in the elimination agenda, and the importance of primary health care and universal health coverage are integral. We look for Global Fund HIV information note, and we recognize that this is beginning of great things in terms of information and integration. And we thank very much Finn for those 4 initiatives that will help us to raise the funds that we need. We also have received information from Dr. Maria Buti of the European Association for the Study of Liver, who sends her support for the viral hepatitis, World Hepatitis Day and elimination. And to round up now, I would like to call on Dr. Ren Mingui, who is our WHO Assistant Director General, Universal Health Coverage for Communicable and Non-Communicable Diseases, to give us his closing remarks. Dr. Ren, are you on the call?
Yes, I'm online.
All right, then over to you. You have the floor. Thank you.
Thank you very much, Phumni and Nicholas, distinguished panelists, speakers, dear colleagues and friends. We appreciate you all attending this very important webinar discussion. It's been a memorable and inspiring event. Indeed, hepatitis is one of the most devastating diseases on earth, but it's also one of the most preventable and treatable, with services that can be delivered easily and cheaply at primary healthcare level. Hepatitis care must be brought closer to the communities and people who need service. Much has been accomplished in 8 years to meet WHO's ambitious hepatitis elimination targets of reducing hepatitis incidence and mortality by 90% and 65% respectively by 2030 in line with global strategy and SDGs. We thank our panelists from the partner organizations and country programs who have shared different lived experience, perspectives, and solutions to bridge the major gaps in the hepatitis response. We particularly appreciate the community voice, the powerful and the competing stories from various countries and different regions. We must use the COVID-19 recovery and resilience to redouble our efforts to improve the access to healthcare and the primary healthcare, including inclusion of viral hepatitis prevention and care into the national health benefit package. We need to explore opportunity and important synergies that can be found in collectively eliminating multiple diseases and combating HIV, viral hepatitis, and STIs, and other communicable and non-communicable diseases together. So I thank you all again and wish you a happy World Hepatitis Day. Back to you, Fumi. Thank you all.
Thank you very much, Dr. Red. You've said it all. And I'm going to ask that we all give ourselves a huge round of applause and wish everybody a happy Hepatitis Day. Thank you very much. And over to Project Echo. Thank you. You can close us out.
Thank you, Dr. Finmay. Sachin, can you close it for the day?